So my name is Amy Kurtz. I'm a physical therapist at Northwoods Therapy. We've got the pleasure of being right next door to this facility and also next door to the physicians. So try to keep up with the pace of changing plans, and I can try to be a resource for you guys to build what we're looking at as a pre-physical therapy course, not only for fast-track patients, but also for anybody who's having a total knee surgery, a uni knee surgery, a direct anterior hip, and I don't care how many days they're spending at the hospital trying to get a consistent message to these patients. So I bounce from 3 different locations, so calling me is almost impossible, so I shouldn't have put those first. Emailing me is probably a lot easier, so if you have questions, definitely feel free to send me an email. Our website has the protocols loaded on them, so we take the doctor's suggestions, load them into protocols that fit on one page, and post them to our site. Often our site is probably the most up-to-date. By the time I get it to Dr. Stewart and he gets it to his web planner, sometimes there can be a little lull in there. So if you're looking for the most current protocol for any of the physicians, you're going to want to check out the website. So today's focus is on the Mako-assisted fast-track surgeries for the uni knee and direct anterior total hips, which you already heard about. And I have to look at my screen to know what I'm supposed to make sure that you know from a physical therapy standpoint what you want to be doing with your patients. So what exercises, gait, safety, home, how can we make their stay at Oakleaf what it needs to be to get them ready to go home, and a prescription that you should be looking for that will now be coming from the physicians so that when they arrive in your clinic, you know what procedure they're having, what you need to do, anticipated length of stay. That prescription, I think, is in your handout. And I was going to, maybe I can pull it up here. Just kidding. Yep. Just kidding. All right. But now I'm stuck. Do I have to click on this one?
Yep.
Go here.
Does it end slideshow? Do you have a document?
Yeah, I do. Well, you can all have it in your hand. So that document is, can I just borrow yours?
Sure. Oh.
This one.
Oh, sure.
Goes like this. Okay, this is the one that's going to be coming from the physician. So you'll see on the top the patient's name, date of birth, diagnosis. So obviously trying to make sure that you know what's going on in that joint. If there's any precautions, ligamentous instability, other issues, osteoporosis, weight-bearing issues, hopefully they'll get that message to you if they happen to know it ahead of time. Pending surgical procedure, so the direct anterior, the posterior, the uni knee, and the total knee. Now, all of those are on there because, again, when we're trying to send a message, at some point this prescription might come from Dr. Berg or Drobert or Carlson or whoever is doing a joint replacement so that you are familiar with this when it arrives to your clinic. There's not one form for Mako and one form for Fast Track. We want to try to have the same form. Surgery date, anticipated length of stay. So the Fast Track is that 8 to 10 hours. Surgery in the morning or early afternoon. They'll go up to the inpatient floor, see a physical therapist. All their, physically they're doing well and looking at a discharge late afternoon, early evening. 10 to 23 hours, which might mean later or the next morning, greater than 23 hours, or if they're going to that rehab setting, it's going to be that 3 midnights. The next kind of section there, the evaluation and treatment, these will be check boxes. What is going to happen at that physical therapy visit? You can pretty much guarantee that all of those boxes are going to be checked because we don't want to have any reason why insurance is going to think that pre-physical therapy is not a needful opportunity. So their strengths and weaknesses, why do they need to be coming to see us before they've had this surgery? The next one then is broken down into direct anterior specific criteria, posterior approach specific criteria, and the total knee and uni knee we put into the same category. Right now we're using the same protocol for the uni knee and the total knee. It's just that the uni knee patients do amazing. How many of you have seen a uni knee patient of Dr. Crow's? Anybody seen one yet? A couple in the back. They are remarkable. You look at them and you think, there's no way you had surgery. So Dr. Crow is right. Their range of motion will come along a lot faster, but still all the exercises and activities that are appropriate for a total knee. That's why that protocol is put together a little bit like a continuum. If you can do A, move them on to B. If they can do B, move them on to C. You don't have to make them hang out for 3 weeks doing heel slides and hip abduction. We can move them along a little faster. On the bottom, it will list under general criteria. Your job during pre-physical therapy is to get them as much of this education on what's their gait style look like, how should they transfer, how is it going to go to use the CPM, in and out of a tub, in and out of the shower, so that they can get this information with a family member present before they have pain medications on board, before they're nervous about the surgery. For us at Northwoods, it's 1 visit for sure, and it's often a second or a third if it means they need to bring family with, go get their equipment, bring it back to get checked. So you have definitely some discretion there to see how many visits that specific patient is going to need. I would say most, lately we're getting really good at this 1 visit, but that's if they come with all the right equipment. If they're not coming with that equipment, then a second visit happens. So you can look for this to come to your clinic ahead of time. We will be calling, thank you, Oakleaf will be calling to make sure that this person came to pre-physical therapy for a fast-track surgery. It is required. You can treat it like an H&P visit. This person needs to have this information so that they can move successfully forward in the fast track. I did our first ran some people through practicing, and patients are giving us good feedback as far as the information they're leaving with and feeling ready for home. So pre-physical therapy, the first line there is that consistent message from Dr. Stewart or Dr. Crow to myself, to the staff at Oakleaf, anybody that works at Chippewa Valley Orthopedics, that it's not a shock that you're going to go home on the day of surgery, that this is the plan, and that we're all on board with this, and everybody's okay with it, and it's not you're doing what? No, we're ready and we're planning for this. So that's where that consistent message. So looking at your prescription that comes to you ahead of time, hopefully if it gets faxed, or at least before you make eyes on the patient, to know that, hey, this patient's on board with a short stay, they want to go home, and I'm going to be the one who's going to help get them ready. Opportunity for range of motion and strengthening prior to surgery. If they can obviously learn quad sets and straight leg raises and heel slides and different activities beforehand, they're going to come out with a more mobile, stronger leg. I don't think that's anything different than physical therapists have believed for a long time. I find that the education to the patient and the caretakers is key. There are people who had, a knee replaced 10 years ago, and they're shocked to think that hospital stays have gotten shorter. How am I going to prepare for this? So bringing those people up to speed on what we expect of them, and have them all come. Anybody who's going to be involved in those first 3 or 4 days of care, they really need to be in attendance at this physical therapy visit if they can. So the shorter hospital stay directly related to better education from all of us, all staff members, nurses, therapists, MDs, awareness of what the procedure is and how it can be handled, and preparedness for all of the above. And we have a lot to juggle. We have patients who are going home the same day, 23 hours, 2 days later, 3 days later, and just making sure that, we're keeping that patient in the know on what their plan is and how to get them ready for that. So in addition to coming to therapy, we want to make sure we try to help them with the durable medical equipment that they're going to need. They show up here and they've got a 4-wheeled walker and a 2-wheeled walker and crutches and canes, and trying to get that narrowed down at that pre-physical therapy visit as what's going to be your reality for the first couple days. You need crutches to get into the house, and you need your crutches or a front-wheeled walker to get around your house. So making sure that at that pre-physical therapy appointment, we are tackling that. There is also in your handout, I'm not even going to try to pull it up, there's a prescription.
I did not realize
Okay.
that, but
That's okay. There is a prescription that will come, because the question is always then the patient gets to you and you realize they're going to need these pieces of equipment. We have put together a prescription where the items can be checked. The physician can sign off from it. If it doesn't come with the physician, a simple phone call to Chippewa Valley Orthopedics will take care of very easily getting that patient that prescription to take to Walgreens or wherever they happen to be going to get their equipment. So they don't need to wait and get it in the hospital. We can get that process rolling. So there will be a form that will come with them as well. Their other sheet in there, this one, is patient's fast track recovery checklist. So the patient will be getting this to help them keep track of all the appointments they need to go to be ready for this fast track surgery. So obviously the date of surgery, important to know. The preoperative physical exam, your H&P, must be completed. Joint venture. Joint venture is the class that's offered here at Oakleaf leading up to total joint replacement for knees and hips. It is offered on various days of the week, and Oakleaf will reach out to the patient and get that scheduled. That has everything from, obviously, how to find the place, where am I going to be located, what does it look like, meeting the nurses, what can I expect the day of surgery. So it takes some of the worry and anxiety out of the hospital experience for people who have not had surgery. The pre-physical therapy appointment, date and time, we are encouraging people to get to know the therapist in their community, the therapist that they are going to work with after surgery, so that you are a familiar face when they come to you 2 days after a total knee and are now ready for the rest of the adventure. So we want them to come see you 2 to 3 weeks prior to surgery, and then we also want them to know the next line there, when is their first post-op appointment. We are setting that up ahead of time. We're not going to be calling from the hospital as much and trying to squeeze these people into different places. We want to get this visit scheduled, and it would be wonderful even if it was the same therapist. If we have 2 or 3 weeks to work with, there's greater likelihood that that is going to happen. Again, the marker for taking care of any prescriptions for those assistive devices, and then if they need to take care of any pain medications ahead of time. So that is for the patient's record, so that they can keep all of this straight. In the fast track situation, these patients are younger people, 40 and 50-year-olds. They happen to be working. So they're trying to do this as efficiently as they can, maybe all of it in one day, so that they're taking less time off of work. And with our older population, that's not as much of a concern, but with that younger population, we're trying to be as forgiving as we can to get them maybe to PT and their H&P and joint venture. I've seen patients try to pull it together in one afternoon if they can. The joint venture class is often offered later in the day, 4 p.m., 5 p.m., so that we don't have to take away from as much of the workday. By understanding the value of those appointments, when the patient comes to you, or even if you're talking to a person who's not sure if they're ready for this adventure, you can help them understand why all these appointments are really, really important. Joint venture, so going back to that, attendance is required. Oakleaf nurses are the instructors. So they are nurses from the inpatient floor, from the recovery room. They are the ones helping the patients understand. And we've had classes in this same room with 20, 25 people in them. So our attendance numbers are going up and people are walking away with very favorable information. So, like I said, email is the best way to contact me. It was hard to put together a presentation that basically covered everything you'd want to know. And so I thought your questions would be better as far as, maybe specific to your therapy practice, your clinic, and how I can help you build a program for your patients. Yeah?
If they schedule their preoperative appointment, will they come then with an order for their postoperative so we could get that scheduled? Will that come down the line?
So the question leads to, when they come to their pre-op appointment, will they have an order for their post-op appointment? When they schedule surgery at Chippewa Valley Orthopedics, someone from Chippewa Valley Orthopedics will call you and set up that pre-physical therapy appointment. They've got the surgery date so that at the same phone call, they can set up the post appointment. Information will be faxed to you. When the patient leaves the hospital, we often ask them, where are you going for therapy? And they're going to Cumberland Memorial Hospital. That order from the hospital then will also be faxed. So maybe there's a change in weight-bearing status. That information that's more accurate now to the surgery will be faxed, even though we already know the date. Yeah?
How long are the precautions in effect? There seems to sometimes be confusion with patients on that.
For the hip range of motion precautions?
It's a really good question. Now, with the direct anterior approach, I showed you the position they need to avoid.
For how long?
Well, basically, we've kind of taken away from even telling them that. I mean, they just don't do that. So we just tell them that. What I tell them in the office is just don't wrench on your hip for the first 3 months. Don't push it further than feels comfortable. And that seems to be enough of a restriction to keep them from doing anything untoward the first few months.
For that combined motion, but what about just hip extension?
You try to extend it without rotating it, it will not come out. You cannot extend it. I mean, we should, at some point, if I revamp this talk, or if anybody's interested, by the way, as a physical therapist, you're welcome to come and observe surgery. You'll see what we do to test the direct anterior approaches. I put their leg in extension, I externally rotate, and I take a bone hook, which looks like a giant gaff for pulling fish out of the water, and just yank, and it doesn't come out. It's just an intrinsically more stable position. So we've really backed down on restrictions. Used to be everything. Right now, it's almost nothing. We just tell them, just don't wrench on your hip in those first 3 months.
And a lot of them, you can't lay on your stomach. It says in here.
Yeah, we said that, and because potentially you can hyperextend your hip. And I never understood people laying their stomach anyway. They suffocate. I had suffocate once now. Yeah, I tell them that, there's probably not a very comfortable position for their hip, and they should avoid that. At the same time, I tell them they wake up at night and they're facing down, and their stomach, probably nothing bad has happened, but we just recommend side sleeping and back sleeping for the first few months.
And in PT, can you get them prone just to kind of stretch out? Sometimes they're really tight in the front of their hips.
You can. I mean, you want to avoid extension and external rotation at the same time because potentially it could come out. But I think stretching them is important because we tighten the tensor fasciae lata muscle, and so stretching that and then taking a roller. And I tell patients, really aggressive patients, 2 months out, they can do the foam roller themselves if they're up for that. But that is the compartment that will be a little sore. So yeah, they can go into some extension if you watch the rotation. But I wouldn't push it really hard the first couple of months.
Have you seen any come out?
We had one very early person, paradoxically, went out the back. Out of the first was at 344, so we had one go out. She was gardening at like day 10, and so that was a hyperflexion rotation, an elderly person. And I think I would have qualified as maybe wrenching on the hip. And it wasn't. She didn't become a recurrent dislocator, so she got reduced, and then she never popped out again. She didn't get surgery again. But just modest restrictions. Just don't push it really hard in the first couple of months, and that's enough. It's hard for patients. You start putting 2 motions in a row for them to remember. Right. Don't extend and externally rotate. They have a hard time remembering which way is external, which way is internal. We just tell them don't push it further than feels really reasonably comfortable. That's the only restriction I'm telling them right now.
In any direction.
In any direction.
A lot of times, just because I'm not sure what the microphone picked up for Dr. Stewart there, but we tell patients that really comfort and pain is their guide. We used to use the word restriction. We got rid of that word. Then we used precaution, and now we don't even use that word very much. But if you are comfortable in the movement pattern you're doing, you are probably okay. And as long as you're not, out gardening really early or trying to do more than really is physically possible after a surgery 10 days out, you are going to be safe. Patients will ask me, can I take a big step? Well, you can't do this, but they start taking these little tiny steps, and you really have to encourage them just to listen to what their body is telling them. And because they've had pain for so long, they're so used to pain, they forget what normal stretch responses feel like, that once they start to, trust a therapist and work a therapist and realize that, hey, this is all working together, they really do well. But we stick with that 3-month because if we put anything less, then they would try to do more earlier. By 3 months, they've obviously done a good course of physical therapy. They've seen their physician a couple times, and we can start to tell them individually, hey, you're ready for this, whatever that might be. Other questions?
Can you talk a little, sorry.
Go ahead.
That similar concept with regards to recommendations for kneeling after total or partial knees. Recurring question, is that more comfort?
So, question about whether kneeling, there's, unfortunately, no matter what approach you're doing for partial or total, you're going to be making a decision at the front of the knee. And so, have seen anecdotally that patients can kneel more readily and less pain with a partial versus a total. But still, there's going to be a subset of patients that just because of the scar on the front of their knee. Now, there's no danger to the component. I mean, now if you kneel on an incision right off the bat, I mean, in the first 2 weeks, that's probably not a great idea. But beyond that, I don't have any restrictions. But patients, especially people who are younger, who are still working, and those kind of patients that we're operating on, they ask, am I going to be able to kneel in this? And it's a roll of the dice. I mean, it's just hard to predict. I mean, and it's just because of the incision, And
Sure.
so, but because it's less invasive, we're not coming down the tibia quite as much. We're not tending to do as much releasing across the front of the tibia. There's less scarring, and patients are more likely to be able to kneel. But there's still some that have discomfort with it. So.
And a lot of times we tell them, and I'm sure some other people have come up with other phrases that work, but, investing in really good knee pads, if that's something that they do need to do, that you probably just can't go kneel on your concrete sidewalk and garden. But if you got a really good pair of knee pads, you could do it for 15 or 20 minutes and be okay. And I think using that, again, bringing those into the clinic, checking it out, we do a lot of that kind of practice as we go with these patients, and they report that they do fine, but they're nervous about it. And of course, if they're on the internet tells them they should never kneel on their knee.
There's a lot of patients that think that their knee's going to fall apart.
Right.
No problem goes off.
Right, exactly. Have them stay away from the internet.
When you're looking at rehab for partial versus total, how do the discharge times generally differ? Do you see a little bit earlier?
Yeah, we've seen, even though there hasn't been a ton of them, and because Dr. Crow is, all over the region, I don't see a lot of them directly at Northwoods, but I would say we're looking at 3, 4, 5, maybe 6 weeks of therapy versus a total we all know could drag out to 16 weeks if they got stiff and sore and weak. So it's pretty drastic from what we've seen early on. And when you are going to build some of your handouts to give your patients for this pre-physical therapy, similar to that protocol that Dr. Stewart pulled up, on the far left of those protocols, it lists the acute care exercises, ankle pumps, quad sets, glute sets, heel slides, shorter quads, longer quads. Those are the acute care exercises that they're going to learn either at the hospital if they see a therapist here, or they should immediately start doing. So on the total knee protocol and the direct anterior protocol, those exercises are listed there, so you'll know what to give those patients of yours. Yes?
Has there been any change in the fast track discharge pain medication expectations, if there's a Friday, Saturday discharge with what the patients are going home with?
We haven't made any big changes as far as medications. I mean, every patient's going to have kind of a unique pain management plan that you have, but we're not trying to put patients on like a short course of long acting like OxyContin or something just because we're worried about them having pain. I mean, generally speaking, really the medications that we give pre and intraoperatively are really controlling their pain for the first 24, 48 hours. I mean, the multimodal pain management has just been amazing in the differences.
But some of the things we do differently now is we give them their prescriptions before. So if they're on the fast track, they're not trying to, get in, get surgery, get home, and someone's got to fill the prescription that same day. So we're going to give them those prescriptions at the time that they're scheduled. And they're told, these are for after surgery, so they get a hold of them ahead of time. Just unloading that period of time so it's not so hectic. So a lot of our patients, my patient on Thursday, I want them to have to try at the end of the week, get in there and get that prescription. But if anything, we're seeing less need for narcotics with the multimodal pain control, smaller dissection. And then the other thing we have to change is if people are going home the same time, they're going to have to get a long-acting antibiotic. So we're going to give them Rocephin versus Ancef at the end of so that they have parenteral IV antibiotics for at least 24 hours, even if they don't stay 24 hours. So just a few medication changes, but some of it's mechanical, not so much different medicines as how we get it to them and when we get it to them.
Yeah.
Dr. Stewart, at one point there was talk about will the hips be going home with the drain tubes?
No, we'll probably get those out.
Okay, I just wanted to make sure if that was something.
We had talked about that. The data on drain tubes is all over the map. You can't statistically show improvement, but we're hoping that by taking some of that fluid out, they're more comfortable after surgery. So we're still going to use drain tubes. We'll probably pull when they go, whether that's 6 hours after surgery or 8 hours after surgery or the next day. The other thing we're changing right now is Xarelto. So a lot of us are switching from Coumadin to Xarelto. We're trying to see if that affects how much bruising and bleeding you get. Hopefully that doesn't. But we've got those things in play right now. That's a good question.
When do you allow patients to start taking anti-inflammatories for pain control instead of a narcotic?
As soon as they're off of their anticoagulant. So having both an anti-inflammatory and an anticoagulant, you have the potential for GI bleeding that's just probably too high. So when we're switching Xarelto, the good news is the course of treatment is shorter than Coumadin and seems to be effective with less days on, so they'll be back to their anti-inflammatory sooner. So that's an advantage we're hoping to see with that shorter oral anticoagulant. So it's a good question.
Yeah, I do the same. So on my knees, I'm doing 2 weeks of anticoagulation, and after that, they can go to any ends that they like.
Do you make them have a TED hose for the hips?
I do. They hate that. I make them do it for until they come and see me at 10 to 12 days after surgery. If they're moving around well and they're doing well and they don't have any edema, I'll tell them they can discontinue the TED stocks then. But we've gone back and forth. I think we're going more to the below knee. I don't know what your feelings are on that, Austin. But
Well, the tricky part with knees is the below knees will sometimes roll up on the incision a little bit.
right, then it's worse than nothing, right?
Right. So yeah, so I do thigh highs, and I'm the same way. I have them come back and see me. If they're still having edema below the knee, then I'll have them continue. If it's just kind of around the knee, then I have them switch to just like 8-strap compression. But yeah, TED hose they work, but people hate it.
Some success if you tried the tuba grip. I've had some success with that helping edema, but sometimes they still get edema in their foot, so you need the whole TED. So we struggle with that. As you know, for therapists, if they just spend enough time laying down and put their foot up, they hardly need the TED stocks. But sitting up, getting on the computer, emailing people, sit for 2 hours, and then they come in all swollen, then how are you supposed to get the leg to bend, right? Because it's swollen all the time.
Dr. Kerr, are you sending patients home with CPM with a partial?
So I do not, no. Now, if a patient requested, I'd be willing to, but as a whole, I'm not a huge proponent of CPMs, but for partials, we're routinely not doing CPMs.
For totals, do you use them, or?
So that's been a debate. I don't, and but some of my patients are requesting them, and the standard practice in this area, a lot of patients are having CPMs, and other surgeons are using them. But I think there's a reasonable amount of literature that says CPMs don't make a difference, and so. One of the things I worry about is that sometimes patients think that is what their therapy is. Like, yeah, I set my CPM. It's like, that's not the same thing, as we all know. So I actually try to steer my totals and my partials away from them. But some people just, they have their uncle and his knee worked great. And so it's like, okay, I'll acquiesce that. But I'm not a huge fan of those.
And as a group, if we're seeing people up on the inpatient floor here, we're trying to find ways for them to get their mobility. So sitting on a large exercise ball, rocking back and forth, that slick surface, seated knee flexion. We want them to be upright. We all know it's better for them to be upright and not in the bedroom laying in their CPM for 6 hours per day. So given the opportunity, we actually have those large exercise balls here on the floor and can have them sit on them and start to get a feel for that more aggressive motion where they're in charge of it and they can play it out to what feels good to their knee early on, and then trying to get them on that stationary bike as soon as we can. I think currently the company we're working with here authorizes the CPM use for about 3 weeks. As a therapy group, if we are getting someone on that ball and on the bike and their range of motion is improving, I'm having them send that CPM packing as soon as they can. And they should come right to their house and pick it up. They shouldn't have to bring it anywhere. Don't let them bring it to your clinic. They should just come right to their house and get it so that they can get a more active recovery going. I tell patients it's just a tool. It might feel good. You might hate it. It's not a real solid answer for that, but trying to find an active range of motion pattern, sooner the better. Yeah?
Is it faster with Mako as far as doing your surgery?
That's a good question. Originally, it was slower. Because there's a little learning curve. I'd say the first 20, it was clearly slower. I'd say now it's probably time neutral. So, you have to do a few more steps, but some steps you can do more quickly with more assurance. it's faster than navigation, which was that step between, just X-ray and Mako. It's faster because I don't stop to wait for the computer to tell me as I'm doing it. I'm getting a lot of feedback. But I'd say right now, I'm just getting to time neutral as we're approaching 100 cases. So before that was a little additional time. Not dramatically. When you're talking from the time we cut the skin to the time we sew up, now it's about an hour.
Well, I'm looking more at as I get older and grayer, and I come down from my hip or knee. I just see some patients coming back possibly with a little bit of confusion, or possibly pre-Alzheimer's or dementia, and I want to be under as little as possible.
Right. So
And
that's
is there a relation between even anesthesia and
the question. So everybody can do this. Again, these are like great questions, actually. The question is post-operative confusion, and not just acutely, but over weeks or months even, and how that relates to arthroplasty. And there's a lot of data on that. That part of that we blame anesthesia because it's not us, so it's easy to blame anesthesia. And then part of that might not be anesthesia. So part of that might be the metabolic stress of the surgery, and there can be some micro fat emboli that occur during the reaming of the acetabulum, but more importantly during the preparation of the femur. We can actually cause material to get out into the bloodstream that goes through. It has to go through your veins and then up through your heart and then through your lungs to get to your brain. It's got to go through your lungs. Or if you have a right to left shunt, which about 10 to 15% of people have a right to left shunt and they don't know that. That means a little defect between the right and left atrium. So blood sometimes can go from the right side of your heart to the left side of your heart without going through the lungs to filter it. So if you have a person with a right to left shunt and they have the total hip, and then they get some small fat emboli from the total hip, that can go to their brain and cause, trauma to the brain. It may be below the level where it's called a stroke, but it can cause trauma to the brain that might affect their thinking. So people have studied this with something called a transesophageal echo. So if you put an echo down the esophagus when somebody's having a hip replacement, you can watch for debris. The debris is much less with an uncemented hip, which is all that I do now, but previously, when we would cement hips, you would actually force a lot of marrow content into the venous circulation, or get into your venous circulation. If you had a right to left shunt, you could have substantial post-operative confusion that might last days or weeks or months from that process. So some of it might be anesthesia, some of it might be this other process we're talking about. Some of it might be post-operative narcotics, which are really trying to cut down. Narcotics, as you know, don't make your hip better, they don't make your knee better, they make your brain worse, so you don't care about your hip and your knee. So, but the residual, some people take a 2-week course of Vicodin, and they're not thinking the same for months. So that's a really good question, which we look into it, and it's probably multifactorial. But if I was really concerned about it, you can you don't need a transesophageal echo to see. You can regular echo to see if you have right to left shunting, but it has to sometimes be dynamic. Sometimes you might not shunt right to left unless you get in a certain hemodynamic situation. The other thing is now with the Alzheimer's thing, in this very room I heard a groundbreaking talk from Dr. Dow, the ophthalmologist, that Alzheimer's is based on these plaques in your brain, but your retina is basically an extension of your brain, and they can take a digital photo of your retina and see if you're going to get Alzheimer's 5, 10, 20 years from now. They can actually measure that now through a retinal scan. It's like computer analysis of a digital photo of your retina. So if anybody's interested in that topic, it's in here. I heard about it. It's fantastic. You can depends if you want to know, right? But it lets you know well in advance your risks for Alzheimer's, and then how they can measure it probably a decade or two before you show any clinical symptoms if you're at risk for that. So that would be another factor for confusion after surgery. Great question.
Any other questions?
A few of my pre-op patients do ask about the likelihood of stress fracture. How has it improved, the last few years with regard to your experience? Because sometimes some of these patients aren't even set to post-op because functionally they're doing good. However, sometimes we get a call if we saw if they were our prior patients, how do you know if it's a stress fracture, or is it just like a normal hip post-op pain? And even before pre-op, they always ask us if we actually see them for pre-op PT. What is the likelihood that I will get a stress fracture? Has it improved
it's a good question. So we can hear it. Stress fracture, what's the incidence of stress fracture after hip replacement? You can see it after partial knee replacement as well. And then what can you tell your patient? So if you look at that 340-some patients who had a direct injury, we had 2 patients with stress fractures in that group. They were both older women with, severe osteoporosis and on steroids for lung disease. In both cases, it turned out. So I think the general population, it's a fairly low risk. If you take a relatively healthy person, I think the risk, that's worse than my previous 350 posterior patients, because I don't know if I maybe even had one in that group. I think the risk is a little higher because they don't hurt. So we kind of encourage them to go as fast as you want. Now you'll see in our protocol, like Amy said, you should look in the protocol. If I see someone's bone quality is questionable, I'll tell them to do 50% weight bearing for 3 weeks to reduce the risk of stress fracture. How do you know if the patient has a stress fracture? If you may have seen it, the pain in the hip will be not a bruise, an ache, but every time they put their foot down, it's like, it hurts to bear weight. So if stress immediately reproduces the pain, then they should back off and you get an x-ray. If you see nothing in the x-ray, there's a lot of patients who have what I call a stress reaction, which means the bone is just hurting more than we would anticipate. And I'll change those people. Often they're going from full weight bearing back to like 50% for a few weeks. And usually that stress reaction will go away. If you look at like a CMS database, the risk of fracture after total hip arthroplasty is somewhat appreciable. I mean, it's not negligent. It's approaching 1%. But most of those patients actually may have the fracture during surgery. I think Mako reduces that risk because, if you plan on an x-ray for a certain size implant, you're pounding that in, and it doesn't fit, you pound it a little harder, you're more likely to get an intraoperative fracture. But with this, we have a much better idea of what implant is going to fit, so you're less likely to run into that situation where you think a 5 should go in there, but really only a 4 is going to fit in there. So I think we'll have to gather more data eventually, because you need to look at hundreds and hundreds of patients to see that. But I think we'll see the risk of stress fracture, or actually intraoperative fracture, will go down with the Mako. I'm hopeful of that. So that's a good question. Stress fracture after partial knee?
So it is something you can see. I mean, all the advantages we talked about with partials, the one theoretical drawback is that because you're only resurfacing a portion of the tibia, you're now placing in that metal component, cementing it in, and it has less bone support. So there are certain things that we can do on a technical aspect that decrease the risk. So basically an appropriate fit of your tibial component greatly decreases your risk of a stress fracture. So that's the one, just like you mentioned, the sizing is very important. So like I talked about in my talk previously, we think that the margin of error for partials is fairly small. So you need to be very precise with how you place them, and I didn't really talk about, but also the size. So when you place your tibial component, and to a lesser extent your femoral component, it needs to fit the anatomy very correct. So when you look at a tibia, and when we resect the bone, as we know there's hard cortical bone on the outside, and the softer cancellous bone, you need to have your component supported by that hard cortical bone. And so if you undersize your component, your risk of stress fracture goes up greatly because all of a sudden you have this cancellous bone that's supporting your component. So the risk is low, not zero, but appropriate sizing is a great step to decrease that to, say, negligible, close to it. We don't see it very often, but inappropriate size components, you will see that happen. So that's one thing that may go, again, we know exactly what we're putting in there and the exact fit to their anatomy. So that's one other really good benefit for that.
And from a therapy standpoint, we find ourselves telling people that even though they feel as good as they do with excellent pain control and, the surgeries are getting better and better, is to keep that assistive device with them. They want to ditch it because I'm walking without a limp, and they said when I'm walking without a limp, I didn't need it. Well, you maybe don't need it from your bedroom to your bathroom, but these people are out going to church and getting coffee and heading to big stores, and they need to keep that assistive device with them and educating them on it. It's a bone, and you had major surgery, and it's healing, and I know you feel like this pair of crutches is slowing you down, but letting them know that that's the why behind keeping that device. And so we have not put hard time frames on people, but 2 weeks is kind of a number we've been using regularly, sometimes 3 weeks in some of these females that are more questionable on their 50% weight bearing, and pulling out the scale and saying, this is what 50% feels like. So I think, just putting it out there for them and letting them know that this is pretty important stuff, and that in 3 weeks you can be free of this thing and do what you want to do, but we've got to be really good here for the first couple weeks. Mm-hmm.
With the partial knee replacement, does that change? Have you found any research or anything that changes good or bad with development of like arthritis in the opposite?
So so basically, if you do a medial development,
Right.
lateral sided, yeah. So the question was, do people have progression? and that is one of the reasons for failure, but it's actually not very high. And traditionally, people who have the kind of standard varus alignment to their knee, their lateral compartments look pristine. What we will see is that they'll have some patellofemoral involvement, and there have been a number of large studies that have looked at progression of patellofemoral disease, and it really isn't that high. Even patients who have some spurs and a little bit of narrowing, unless it's marked, like eburnated, just completely exposed bone, some people are. Now I'm a little more selective, but there are surgeons who have put them in there and show x-rays of patients who have bone-to-bone patellofemoral disease that do a uni and say they have good outcomes. I'm a little bit less confident in that, but to look at progression, it's not very high. We do see it. Now, there are some patients who, through poor patient selection, if they have pre-existing disease, then they're going to be much more likely to progress. But when you do this, even though we're only doing that medial arthrotomy, we flip open the kneecap and look underneath, and I can look at that lateral compartment and the patellofemoral compartment. And there, I can send all my patients, even though 90+% of the time I go in there knowing exactly what I'm going to do, I can send them for a possible total, because you never know, if we get in there and there's a large defect. I mean, the last thing you want to do is do a big surgery and just have them not be happy. No one's happy then. I'm not happy, but it's an uncommon occurrence. We usually have a pretty good idea going in there, but you can see it, but it's not as common as you think.
All right.
Wrap it up.
Mm-hmm.
We'll be around for questions in
Yep.
small groups. And I'm going to change, instead of meeting over there for the tour, we're going to meet over here so people can still eat if they don't want
Yep.
to go on the tour. You don't feel like you have to go on the tour. So we'll meet you over